Perfect. Thanks so much. So I want to begin by just setting the stage a little bit as we think about this idea of reimagining how we assess our trainees and what this might imply for the future of surgical education. I have nothing to disclose. I'm just going to offer a couple introductory stage-setting comments here, and then we'll get into our speakers. I will also say at the outset that two of our speakers were unable to travel because of travel restrictions, one of which just came up last week, and that's Dr. Stolberg from Northwestern and Dr. Madani from the University of Toronto. So they will be presenting virtually for us here, but we won't be able to have them in person. So why are we talking about this? And I think probably all, certainly many in the audience will be well aware that the issue of our end product and what we're producing through our training programs in the United States and no doubt in other countries as well has been called to question in recent years. There's obviously the celebrated MATAR study. A couple of our key program committee chairs and former presidents of this society were co-authors on that paper that was published in Annals back in 2013 after being presented to the American Surgical Association. And you've all heard the data many times, I'm sure, but some of the more damning things that fellowship program directors highlighted was that close to a third of our graduates were not felt to be able to be left alone on a laparoscopic cholecystectomy and make adequate progress on the case. There are other studies based on surveys of both residents and faculty that have raised similar questions, and this has obviously been in the popular media as well as we think about whether we're really preparing surgeons for the world they're going to function in, and how do we know that that's the case. If you look at American Board of Surgery data around the performance of our graduates, and this is obviously only on an examination, it doesn't refer other than by attestation and case volume experience to their technical skill, but there's over a third of programs where at least a third of the residents, if not more, fail to pass their written and oral exams the first time around. So just the scatter on that plot, I think, highlights that there's some opportunity for improvement in the standardization of the product that we're collectively producing. If you look at technical skill data, at least as assessed through the Simple app, which I'm sure all of you are familiar with, this was published in Annals just a few years ago. More than 10,000 patients, more than 500 residents, more than 400 distinct attending raters. And the key thing, what you see in blue on this slide, would be people that are needing enough help or not even being able to do the operation that they certainly wouldn't be considered ready for autonomous practice. And for some relatively common operations, that's a sizable number, upwards of 30% for things like colectomy. And if you get into non-core procedures, the number gets above 50%. And even for some less common core procedures, such as splenectomy, over 30% of the graduates nationwide, and these were assessments done in the last week of someone's chief residency year, so not global residency data, but how are they finishing? What do attending raters think of their readiness for independent practice as they're finishing? Some sizable gaps to close for operations that we certainly hope that they would be able to do. So we've been talking about competency-based education and various models of it for 40-some years now. If you go back to early publications by the World Health Organization, our Canadian colleagues have really been leading the way in much of this, and we're delighted to have a couple of them on our panel today. Really asking ourselves, what does this look like? How do we apply it? It's something we've been struggling with for some time, and I hope we can get into some of the current iterations of that conversation today. So we've got an all-star lineup for you. I'm going to first invite Melissa Hansen to the podium. I'm just going to briefly introduce everybody now so that we can move through the program, and then we'll have some time for discussion after all the presentations. Melissa is a fellow at McGill. She's been very involved with SAGES this year. I've had the privilege of meeting her up till now only on Zoom calls, but she's been working with our Reimagining the Profession of Surgery group, and also is very active in the EPA domain, which is what she'll be educating us about today. Then we'll have Jonas Stolberg by pre-recording, who's at Northwestern and just found out last week that due to new travel restrictions there, he couldn't attend. And then Addie Faber, who's with the Academy for Surgical Coaching. Addie has tremendous expertise around training surgeons to be coaches and using coaches as an extension of the video paradigm or as part of an in-person coaching event to enhance skill. And then Amin Madani will close us out, again from the University of Toronto, talking about artificial intelligence and how it may relate to these themes. So that being said, thanks for being here. And Melissa, welcome to the podium.